Hello, my name is Iman Simmonds. I'm from the University of Buffalo, and today I'm presenting as New York State Good at managing hollow viscus injury. Okay, so I have no disclosures, no relevant disclosures. This is my team. So our presentation basically has a primary aim of evaluating whether or not using key performance indices identified by the National Quality Forum to identify whether or not New York State's quality of managing abdominal trauma is good. We use SPARCS, which is a key principal component of New York State's comprehensive trauma registry to do this. And the reason, our rationale for doing this was that trauma involving the torso is the leading body region that results in hospitalization in the US. It also is the second most common cause of hospital costs, second only to brain trauma. Also, according to the National Trauma Data Bank, abdominal trauma has the highest case fatality rate of all truncal injuries at about 12.75. And according to their data, it is increasing. So we took data from SPARCS and we identified all trauma patients who came in who were over the age of 16, greater than the age of 99, who were New York State residents, who did not die in 24 hours, and according to the Bell-Rel Index, had an abdominal trauma. We then identified patients of that group that had a blunt or penetrating mechanism. We got about 31,000 abdominal injury patients. Of that, 7,000 had a hollow viscus injury, and 2,900 or 3,000 had a colonic injury. We then looked at measures that assess the accessibility, timeliness, and outcomes in accordance with National Quality Forum. Our results showed that in terms of our patients, abdominal injury patients tended to be white males. They had privately insurance, and overwhelmingly they got there because of blunt trauma, almost 71%. However, abdominal trauma is not common. It only occurs in about 14 per 1,000 hospital trauma visits every year in New York State. It's higher for level 1, level 2 trauma centers and lowest for undesignated centers. Hollow viscus injury, very similar to other types of abdominal injuries, also mostly white males, however, that's mostly Medicaid patients. Also from a blunt mechanism 60% of the time, but very low, so 2.9 out of 1,000 cases a year. And colonic injuries is the least common, and it occurs mostly in black men, and it's actually a result of 40% of the time, 47% of the time from a penetrating injury. So the results, oh, I skipped this slide, sorry. So in terms of accessibility, we looked at access to level 1, level 2 trauma center. We found that 71% of abdominal injury patients went to a level 1, 2 trauma center. We then looked at measures for accessibility as identified by ASCOT, which takes under triage as patients who were transferred to a level 1 to a level 2 trauma center who had a major injury. The goal by ASCOT is 5%. New York State's around 7%. Then we looked at over triage, which meant patients went to a trauma center and really didn't need to be there, and that was measured by the patient either not going to the OR in 24 hours or that they were discharged within 24 hours. We were at 2.9% and 29%. I'm sorry, the opposite, 72%. The goal is around 30% as for ASCOT. And last we looked at something called resource management, which is how many patients actually required or got a trauma team activation. That was only 16% for abdominal trauma. So there is obviously some room for improvement in terms of access. To measure our processes of care, largely looking at timeliness, we created a map of what would likely happen to a patient who came in with an abdominal trauma in their first day and then their second and then thereafter. So we defined an abdominal workup by scopes, also by a FAST exam, CT exams, going to the OR immediately. And we found that actually 55% of abdominal injury patients got no additional workup outside of a physical exam, no CTs, no OR, nothing. And some of those patients were fine, but a small proportion of those patients ended up having a delayed surgery for a hollow viscus injury, which means that it was missed. So for the hollow viscus injury, around 18% of patients had a delay, and for colonic injury, 19% had a delay. So there is a problem within access to timely care, despite 70% of patients going to a level 1, level 2 trauma center. And that's likely because they have a blunt mechanism, and there is a higher proportion now of doing non-operative management. So then we looked at these two process measures, going to a level 1, level 2 trauma center, and then the second one having a delay in hollow viscous repair. And we found that they were highly associated with our outcomes that are deemed important for this patient population. So 30-day mortality, increased length of stay, 90-day readmission, and postoperative infections. And that was true for abdominal trauma, hollow viscous, and colonic injury, with the exception of a level 2 trauma center, which was only important for ABIs and HVIs. So then, because of the importance of the delay, we looked at factors associated with increase in delay. And we found that if you did not get any workup before you're on day 1, as compared to patients who got a CT, you're almost 300 times more likely to get increased odds of getting a delayed hollow viscous repair. So there are some things in our workup for patients. And then lastly, we looked at colonic injury because it had the highest rates of length of stay, highest rates of postoperative infection, and highest rates of mortality in the state. And we looked at the approved or EAST guideline surgical management of that, which would be a primary repair versus a stoma creation. And we did a propensity-weighted analysis based off blunt or penetrating trauma, and we found that in New York State there was no difference in mortality or leak rate or wound dehiscence. So the outcomes were fairly similar for patients that received either, though most patients received a primary anastomosis. The strengths of the study is that we were able to really identify the number of patients who were seen outside of a designated trauma center, which has not been done previously. And we are also able to track the long-term outcomes of patients with ABI. The limitation is that this is an administrative database, and unfortunately, it doesn't have the great clinical variables that would be used for accurate risk adjustment. And lastly, in conclusion, we have room to improve in terms of our access to level 1, level 2 trauma centers and reducing delays to therapeutic surgical intervention. The rate of ABIs, while uncommon, is largely driven by blunt trauma in New York State. This is a novel approach to using an administrative data set for quality improvement. All right, thank you. And I think my last slide was just an acknowledgement of this research was funded by the Acute Fellowship. Thank you.